When assessing the abdomen, this sequence should be followed: inspection, auscultation, percussion, and lastly, palpation. We shall now begin with inspection. Describe the abdomen as to first, symmetry, second, skin. Note for the color, the lesions, and the scars. Third, the shape. Is it flat? Is it globular? Is it scaphoid? Or is it protuberant? Fourth, the appearance of the umbilicus. Is it flat, inverted, or everted? And fifth, check for visible pulsations in the epigastric region. Ask the patient to momentarily hold his breath. Pulsations may be seen normally in thin individuals. For this patient, on inspection, the abdomen was noted to be symmetrical. The skin is brown, no lesions and no scars, no bulging flanks and no localized bulges, no dilated blood vessels, no abnormal pulsations, and no visible peristalsis and no mass. Up next is auscultation. To listen for and describe the bowel sounds, press the diaphragm firmly on the right lower quadrant. Listen for sounds such as gurgling, bubbling, or popping. Describe the bowel sounds as to normoactive, hyperactive, hypoactive, or absent when no bowel sound was heard after 5 minutes of auscultation. For this patient, on auscultation, the bowel sounds are normoactive. We shall now proceed with percussion. To assess the distribution of air in the bowel, randomly percuss each of the 4 quadrants. Normally, the sound you will elicit is tympanitic. These will not be equally tympanitic though, since the underlying intestines may be purely gas or gas and liquid filled. Also note if the patient is feeling any pain as you percuss. To measure the liver span, start at an area of tympani from below the level of the umbilicus along the right midclavicular line. Percuss upwards towards the liver. Then mark the site where the sound changes from tympani to dullness. This is the lower border of the liver. Start at an area of resonance just about the level of the 3rd or 4th intercostal space, right midclavicular line. Percuss downward and mark the site where the sound changes from resonance to dullness. This is the upper border of the liver. The total span of the normal liver is quite variable, depending on the size of the patient. To estimate the size of the spleen, percuss along the left mid-axillary line, starting from an area of resonance on the 8th intercostal space, down to the 11th intercostal space. Listen for dullness. Normal results would be no dullness appreciated, or splenic dullness over one intercostal space from the 9th to 11th intercostal space is noted. And of course, palpation. Always remember to keep the palpating hand flat and parallel to the abdomen. Light palpation. With the fingers approximated, press the finger pads gently into the abdomen with a dipping motion to a depth of about 1 cm. Lift and move the examining fingers randomly over each of the 4 quadrants of the abdomen. Describe the findings as to first, consistency of the abdomen. Was it soft, firm, or rigid? Second, check for palpable mass. And if you find any, describe as to location, size, shape, and consistency, including tenderness, pulsation, and mobility. And third, check for tenderness. And be sure to identify the specific location. Now for the deep palpation. For the deep palpation, which is usually used to elicit deep tenderness, detect deep masses, and palpate for possible enlargement of liver, spleen, kidneys, and would help you describe them accordingly. Under deep palpation, we have single-handed technique. Using the palmar surface of the approximated fingers, press the abdomen to a depth of about 4 to 5 cm, then glide the fingers back and forth. Palpate each of the 4 quadrants of the abdomen. Now for the double-handed technique. This is done when deep palpation is difficult, like in obese, increased muscle tone, and when the target organ is deep. Place the left hand on top of the right hand. The fingers of the left hand should press on the distal phalanges of the right hand. The left hand reinforces the palpation by exerting pressure on the right hand, while the right hand feels for organs, masses, and other abnormalities. Press the abdomen to a depth of about 4 to 5 cm, then glide the fingers back and forth. Palpation of the liver. Place the examiner's left hand behind the patient, parallel to and supporting the right 11th and 12th ribs and the adjacent soft tissues below. Place the examiner's right hand on the right side of the patient's abdomen, parallel to and lateral to the rectus muscle, with your fingertips well below the lower border of the liver dullness. During expiration, press the abdomen gently in with the right hand as the left hand lifts the back. With the left hand lifting the back, glide the fingertips of the right hand upward during the succeeding inspiration, and feel for the liver edge as it comes down and meets the fingertips. The liver is not normally palpable, except in very thin individuals. If felt, lighten the pressure of the palpating hand slightly so that the liver can slip under the finger pads. Normally, the liver edge is sharp, firm, with a smooth surface and non-tender. We shall now proceed to the demonstration of the hooking technique. This is helpful, especially when the patient is obese. Stand on the patient's right side, facing his feet. Place both hands side by side on the right abdomen below the border of the liver dullness. Hook your fingers around the costal margin or below the border of the liver dullness and ask the patient to take a deep breath. Repeat the maneuver several times and feel for the liver edge as it comes down and meet the fingertips during inspiration. The liver is not palpable except in very thin individuals. Normally, it should be firm, smooth, even, and non-tender. Palpation of the spleen. Stand at the right side of the supine patient. Lay the palm of the right hand on the abdominal wall in the left upper quadrant and place the tips of the approximated fingers just inferior to the rib margin, along the left anterior axillary line. Place the palm of the left hand on the left mid-axillary region of the thorax, with the fingers curling posteriorly to support the thoracic wall at the 11th and 12th ribs. Ask the patient to inspire deeply and slowly through the mouth. During inspiration, bring the two hands closer together by lifting the posterior wall with the left hand while firmly pushing the approximated fingers of the right hand inward and upward behind the costal margin. The Middleton technique. Stand at the patient's left side, facing his feet. Ask the patient to place his left fist behind the left thorax at the level of the 11th and 12th rib. Curl both your hands over the left costal margin so your fingertips are pointing upward behind the ribs. Feel for the splenic edge as the patient inspires deeply. Capture technique. Stand at the right side of the supine patient. Place the left hand just below and parallel to the 12th rib with fingertips reaching the costovertebral angle, then lift anteriorly. Place the right hand on the patient's right upper quadrant, lateral and parallel to the rectus muscle. Ask the patient to take a deep breath. At the peak of inspiration, try to capture the kidney between your two hands by pressing the right hand firmly and deeply into the right upper quadrant just below the costal margin. Ask the patient to breathe out and pause. Slowly release the pressure of the right hand, feeling for the kidney to slide back into the expiratory position.